Hello, everyone. Welcome to NJSHP's podcast, Behind the Counter. My name is Sia Majumdar, and I am a PP2 and one of the co-chairs for the Public Relations Project Chairs Committee. I work alongside Charlotte Duan to create these episodes discussing future career paths with pharmacy professors here at Rutgers. For this episode, we had the pleasure to work with Dr. Jackson-Clark, a Rutgers alumni, a clinical associate professor here at Rutgers, and an internal medicine pharmacist at Hackensack University Medical Center. In this episode, we learned a lot about Dr. Clark's experience as an internal medicine pharmacist and how he balances his life with his academia career. We also dive deeper into his pharmacotherapy residency and issues within women's health. Thank you for tuning in, and I hope you enjoy.
Thank you so much for being here today. So just a
Uh,
first question, can you tell us about yourself? How did you get to where you are today as an internal medicine pharmacist?
sure. I would like to thank you guys so much for having me. Um, so to kind of give you a little bit of backstory about me, I actually graduated from Rutgers, so go Rutgers. I'm
Okay.
class of 2023. After I graduated, I actually did my PGY1 in just general pharmacy practice at Huntington Medical Center, which is in Flemington, New Jersey. After that, I actually early committed to their PGY2 program in pharmacotherapy. So I did my PGY2 in pharmacotherapy. But after that, I ended up getting a job through Rutgers. And through Rutgers, I'm actually an internal medicine clinical pharmacy specialist at Hackensack.
Okay. So why did you choose to work in like a clinical setting instead of like industry or like community?
For me, I kind of knew early on that I wanted to be a clinician. For me, with industry, one of the things that I really kind of wanted to have experience with, whatever career I wanted to do, was definitely patient interaction. So I knew industry wasn't really my jam. In terms of retail compared to like being inpatient in the hospital, I actually worked throughout pharmacy school at Walgreens. And I knew from then that that was not going to be my favorite. So that's kind of what made me gear more towards being an hospital patient.
That's cool. That's
Mhm.
cool. That's- yeah, because
Yeah.
I mean, I'm sure you
Yeah.
get a lot of patient interaction with Walgreens, but maybe just not
Oh,
the.
I did. I did, but it was more so like customer service. Like,
Hmm.
and I'm like, dealing with insurance and everything. Like for me, what I realized actually during my app was kind of being like, oh wait, like I have to actually interact with doctors and ask them to order labs and ask them to do this or adjust this, like right then and there and get kind of that instant kind of gratification. Like that's kind of what I wanted. Because retail, like, and even like other, if going deeper into clinician like AmCare and stuff like that, usually you have to wait and see the results. I could see the results right then and there when we're talking all around. So that's what also kind of made it attractive to me.
Interesting. What does like a typical day look like for you at the medical center?
Sure. So usually in the morning I get in at around like 7:15 ish. Usually I pre-round. So I have about so we my service that I ran with is actually kind of like a step down unit from so say someone was in the ICU and they're kind of in that kind of in between space before being discharged to like the general medical floor or being discharged. That's kind of what my service. So on my pre-round, it's about 14 patients on the service. I kind of round, look at anything. And then rounds typically start at about like 9:30-ish. So usually if I have students with me, I'll meet with my students at about 9 o'clock. We go over their patients. If there's anything pertinent, we'll go to around 9:30 to about like noonish. Then I'll have lunch, obviously, and then afterwards there'll be like any other kind of administrative duty following up on patients if I have any leaders out.
Oh, interesting. So you like, because I don't know, see, if you learned about transitions of care yet? Have you learned about that? No.
No, only organ fist.
Okay.
Only.
But yeah, like from what you just sound like, it sounds like you're really in like the transition part of transitions of care, if that's
Yeah,
correct.
yeah, and I actually do interact with transitional care pharmacists to kind of making
Mhm.
sure that, once if the patients are discharged, making sure that everything is kind of squared away in terms of like cost and
Mhm.
everything is there for them. We do have like meds to beds programs, so
Mhm.
instead of having patients once they are discharged from the hospital, they actually come get their medications delivered to them while they're in the hospital bed. So they could just leave with their medications with no issue. And then of course they'll have to follow up afterwards to get research and stuff like that. But yeah, I definitely interact with transition.
Interesting. Because
Interesting.
I'm kind of curious, and has there ever been a moment where like you had to like have them go back to the ICU or the like emergency
Yeah,
room?
so we've had to kind of make kind of escalate care in the certain cases, especially as things get a little bit more acute.
Mhm.
In that aspect, usually it's kind of just making sure everything is kind of squared away in terms of okay, is everything kind of renally dose adjusted? Are we discontinuing things that are not necessary once they're in the ICU? So, like, I mean, for instance, like nobody's going to need Tylenol PO because you're probably going to be intubated, right? So it's just things kind of that we kind of will have to kind of switch around in that.
Okay.
How would you say like you balance your career at Hackensack with also your as a clinical professor here at Rutgers, like handling your day-to-day life with teaching here?
Uh, I would say it's a work in progress. Every day is different. Honestly, I wouldn't change it for the world. Really, what kind of helps me is definitely planning everything and kind of making sure I write everything down or have a log of everything that I have to do. So, like Google Calendar is my best friend. The Outlook calendar is my best friend. I have reminders on my reminders app on my phone, and just also having open communication with everyone and being like, hey, this is kind of, I'm busy doing this at the moment. I'll reach out or let's plan to do this on this day because I'm typically at Rutgers on this day and things of that. So it's definitely kind of making sure I have a good schedule and planning everything out and being like communicative to everyone.
Mhm.
You
Mhm.
sounds really busy. Thank you so much for making time to come to join us today,
Of
man.
course, of course. Anything you need me to do, I will do it. So this is definitely something I wanted to. So I
Nice,
definitely make
nice,
sure I.
nice. So what courses do you teach here at MSOP? If you don't mind us asking.
So I teach a few courses. So I do teach in pharmacy convocations. I teach a few lectures in there. I'm actually just taught on Tuesday the non-pharmacy or non-traditional pharmacy careers. Um, so that's PP1. P1 I teach in foundation. So I teach like statins, like the statins and the diuretics lecture. And the main thing that I typically teach is I'm actually the course coordinator for women's health. So that's something that I'm heavily into. So doing the Sims, making sure kind of organizing the course and everything. That's my kind of main.
Mhm. Were you like always interested in teaching? Like what drew you to being a professor here at Rutgers and like working with students? Mm.
So for me, I think it was always in the back of my mind. I just didn't know kind of how it would kind of come into fruition. So I actually did have the opportunity. I am a part, or I was a part of, the Educational Opportunity Fund, which is a program for first generation students. So during that program, as I kind of progressed through that, as long as with pharmacy school, I actually had the opportunity to be a counselor. We have to do a summer program in order to kind of be initiated into the EOF program. We actually have to do a summer program prior to the start of PP1, and it's little just like a truncated semester. And we actually had people that like taught courses. So I actually was responsible for teaching like an introductory pharmacy course during that. It was during COVID, so we know how things were kind of insane during that time. But that was a really good experience, kind of being responsible for creating lectures and being able to kind of make test questions and things like that. So that really was like really piqued my interest. And then kind of going through like Appy and doing residency applications, I was really interested in doing a program that had a strong academic component so that I can teach and have that experience. So at Hunterdon, the other co-course coordinator, Dr. Phillips and Dr. Giadetti, they actually taught in women's health. So that's how I kind of got into women's health and taught that class. I've been teaching in this class since I was a PGY1. This will be my third kind of go at it teaching.
Nice. That's interesting. 3 years.
I'm
How
surprised
much?
about the PP1 experience with like teaching. I feel like I would not be ready at like just coming to college, like doing a
Well, I
lecture.
was at that time I was a P2 when I was teaching in
Oh,
that
okay,
class.
okay. Oh, I
Oh
see.
no, no, yeah, I was
I
not definitely ready. I was getting thrown left and right during that summer, but it was a great experience, and it did kind of prepare me for how to this whole kind of ride of pharmacy school with it. So,
That's great. That's great. Okay, so if we can transition a little bit to talk about your PGY2 residency. So
okay.
well, for this podcast, we've interviewed a lot of different specialties, and all like their experience, with, like all the different kind of residencies. But then pharmacotherapy is something that we don't hear that often, honestly, I would say. So, like, what makes or what separates pharmacotherapy residency from like other residencies? What makes it special?
So a lot of people like to compare pharmacotherapy. The closest thing that it could be is like internal medicine, I would say. So a lot of people kind of will group those two together. Pharmacotherapy is, I would say, is unique because in internal medicine, like the main kind of population that you would see would be kind of the acute adult inpatients, right? So that's kind of your general medical floor. A lot of people who are going to crit care, like in the ICU, has internal medicine background. That's kind of where that comes. Pharmacotherapy, I would say, is kind of like you get kind of flashes of IM, but you also could kind of tailor it to be more AM care. You could tailor it to be more onco. You could tailor it to be like anything that you really have a strong interest in. I think pharmacotherapy kind of teaches you the basics of being a clinician, and you could kind of pivot it to what specialty that you want to do. So for me in my residency, because I wanted that kind of inpatient experience, it was tailored to kind of have kind of like an IM experience. What also kind of makes pharmacotherapy different is that most pharmacotherapy programs in the country have a strong academia component compared to IM. Being that I wanted to get into academia, to me, it made sense that okay, I can use this residency to tailor it to IM, which is the specialty that I'm interested in, and also have that academic component, which I'm also interested in. So it was kind of like the best of both worlds.
Mm. So it seems like a very like broad specialty compared to like others coming out of PGY1. Like how do you tailor yourself and like train yourself for the specific specialty you're interested in? Or is it just like you're interested and you like learn through the job or
So during your PGY1, you'll definitely get a lot of experiences or opportunities to have different experiences in different specialties. So usually, what many programs will do is they will tailor their program to make sure that you get some of those a wide range of experiences before you actually start to apply to PGY2. To say, you know what, like of the experiences that I had, I actually really like Onco. And then they will kind of tailor your electives, the kind of optional rotations that you could do to kind of build upon that interest. For me, I'm very indecisive. Like if somebody asks me what I want for dinner, it's like a crisis. So that definitely, if you ask me what specialty I like them all, and that's kind of why I wanted to do IM because it's kind of the best of everything.
I see.
Nice. And then I guess was there any like like specific experience or moment that made you go down pharmacotherapy, like go choose the pharmacotherapy residency, and also like or maybe go down the path of IM?
For me, I would say during my PGY1, I actually was on my IM rotation. So I'm at Hunterdon. We have family medicine residents. They actually do round inpatient and they also round outpatient. So most of the patients that we saw were pretty typical, kind of like IM adult inpatient. Most of them were elderly because it's Hunterdon County. There, it was just a really good experience, kind of like being relied on for like drug information and being able to kind of make adjustments. There was a patient who came in with very poor renal function, and then they were on dosing. I forget the dosing. It was like every like 8 hours. And it was like, we have to kind of switch this because it's inappropriate due to their renal function should be every 12 hours. Kind of making those recommendations, and they'll be like, oh, like thank you. Like I didn't think about things like that, and kind of looking at the patient as a whole and kind of touching a little bit of everything. Like a patient comes in with high blood pressure, diabetes, cancer, has an infection, you kind of could address a little bit of everything. And that's what I really liked. And I was like, I kind of like everything, which is why I want to do it.
What would you say was like the hardest part of your therapy residency, or like the easiest part? I don't know if there is any, but
There, well, I mean, there's some good kind of once you kind of get in used to everything and used to the rigor of everything will kind of come to you a little bit easier. For me, the hardest thing honestly was just kind of really getting comfortable with being responsible for making decisions. I feel like that's always something, once you kind of get comfortable, of course, kind of building your clinical knowledge, right? It kind of takes a lot to take a step back and be like, wait a minute, like I'm actually like making these decisions. Like there's no one kind of checking me, right? Because at this point they're comfortable with me being able to make these decisions, right? So, I often sometimes I do kind of second guess, but it's always going back to guidelines, going back to clinical evidence, and saying, no, I did make the right decision, and this is my recommendation, and this is why. So I think that was kind of the hardest thing for me early on in my PGY2 was like, okay, like now I'm kind of entering the big world by myself and kind of making these decisions, starting to do this. So.
Mm, yeah, that I don't know. That just sounds like very stressful. That the way you describe like the transition from PGY1, where I guess you're still being supervised, but then PGY2, you're suddenly all by yourself. Like that sounds terrifying.
It's fine though. Like I feel like once you kind of gain the experience, like it was like okay, like it's just something that's in the back of your mind, but you know that you have the experience, and kind of based on your experience what the best kind of direction would be. So it comes easy. I find. Don't stress.
I'm kind of curious then, like what kind, like what skill, or I guess what matters more, like having actual like clinical experience or having the ability to like search up guidelines or search up like papers very quickly to get the evidence you need to support your decision. Yeah.
That's a good question. Honestly, I feel like everyone could kind of look up information, right? Because
Mhm.
usually I tell students it's not the fact that you don't have to know everything, but you have to know where to find the information that you're looking for. So I think that is a skill that I feel like, you'll kind of build upon. And then once you kind of get used to looking at that evidence, in a repetitive fashion, it'll kind of be ingrained to you to where you'll have that knowledge. So I feel like they kind of feed into each other.
So what career paths can you go down having done your pharmacy residency?
Like both of them, just PGY1 and two, or
Uh,
just PGY1.
we can do PGY1 for now, since we have our general medicine section later too.
Um, it's a lot that you can do. It's a lot that you can do. Residency really builds kind of those fundamental clinical skills that could be applicable in any situation. Even if, okay, say, you know what, maybe I'm not really interested in doing the PGY2. Maybe I want to go into industry and be a medical science liaison, which is, I've known residents who've done that. Or, you know what, maybe I kind of want to dive a little bit deeper into a certain specialty like oncology. My co-resident did that, and he's now an oncology pharmacist at Cooper. Maybe, I want to go back to school, get my master's in public health and do something like that. I know someone who did that. So, there's a lot of different ways that you can go. I like to say that the PharmD is like a golden ticket that, is redeemable at any stop that you want to go. So there's a lot that you can do with that experience, and it's very attractive to a lot of different organizations and positions.
Mm-hmm. I don't know. I feel like sometimes when I think about like pursuing a career in pharmacy, it seems like overwhelming since we are so open to everything. Like, so as you were saying before, like I'm very indecisive. Like everything seems attractive to me. So yeah, but it's good that like we still have that opportunity to like whatever is like we're open to everything.
What kind of advice would you give someone that wants to do like specifically a pharmacotherapy residence, a PGY2?
Advice. I would say, be open-minded, right? Definitely take any experience that you get or offer and take it to the fullest extent and kind of, give your all in the experience and try to get the best out of it. I definitely would say for people who are doing pharmacotherapy, or even any PGY2, definitely try to work at the top of your license. So, board certification should be something that you think about. You don't necessarily have to do it, but, that is kind of something that, can help kind of elevate you. Of course, there in certain cases are pay bumps with that. So that's something to think about. And also get involved in organizations like NJSHP, like ACCP, like ASHP, get involved in those organizations and always keep your ear to the streets, I like to say, in terms of like new innovations and stuff with healthcare and guidelines, because we've got a lot of updates recently that I can't keep track of, but it's good to kind of have that network and be able to kind of disseminate that information to each other.
Mhm. Yeah. So jumping into internal medicine now and like what you do at Hackensack, we have a lot of like young listeners who maybe not sure of like the exact terminology. So how do you describe internal medicine and what is a pharmacist's role in internal medicine? And what does this does for a pharmacist? Like what does this do?
I like to describe being in internal medicine as kind of being a jack of all trades. This is kind of the practice or the service that will kind of cover kind of a wide range of things. Say someone comes in with like high blood pressure, they have a history of heart failure, they have a history of COPD, they have a history of some sort of metabolic syndrome or something like that. Usually internal medicine is kind of going to cover that. Usually they think of them as kind of like family practice, but inpatient. They kind of cover everyone. And then if we need to kind of refer to specific specialists, say that 5 times fast, you definitely, can get kind of help from the oncologist, the rheumatologist, and things of that sort. So kind of, I like to say like we're the catch-all, and then we'll kind of pull in specific people if we need them.
Mhm. How is it
So
like? Oh, sorry.
So to answer your question with pharmacists and how kind of we are integrated into that, to be an internal medicine pharmacist, you kind of gotta know a little bit of everything and kind of just be making sure you're optimizing the patient as a whole, right? Because oncology pharmacists usually will focus on chemotherapy, supportive management. ICU, of course, is kind of making sure in an acute setting, EM will be kind of in an emergent setting. We're kind of making sure people are steady, right? The other kind of specialties I feel like are very specific, and you're kind of just trying to get them out of that hole that they're in. We're just trying to keep them steady overall. Think about it that way.
hmm So you mentioned like working with other people too, like at Hackensack. So what are like some questions that you get asked the most as the pharmacist on duty? or like yeah, how is it like working with other professions?
It's great. They're very receptive. They love coming and asking us drug information questions. So, I actually could tell you a couple of questions that we got that I gave to the students. Most of them would be like, someone who's on dialysis, how would you dose this medication? Or, is this a side effect that you typically see with this certain medication? So, it was a patient who came in, who had kind of increased ALT, AST. So kind of indicative of liver injury, they will just started on Wellbutrin. So is that something that you see with Wellbutrin, or what's the onset of that? So kind of knowing to kind of dive a little bit deeper into that literature and see that, and it's drug information questions, or what do you think? This patient is coming in, they have a QTC of 480, and they can't be on this certain medication to kind of help calm them down. They feel like they're stressed. What would you recommend? Those are kind of questions that I get. So it's a lot. I never know. It depends on each day.
Dang. Just like I said, it sounds like a lot. And but also like my admiration for like your role is kind of growing because it really is you sound like you are like the person that's in between and that like kind of like the person that sets the foundation for everyone else, which I think is just very cool. Especially because like I said before, we don't hear about IM that much. Especially throughout like our pharmacy schooling. Like through modules, we're learning about specific disease states. We're not looking about learning about like internal medicine or just like what you can do with it, right? And so just hearing about that is honestly it's very cool and very admirable. So, but then my question is, what as an IM pharmacist, like you said, I'm sure one of the challenges is like the fact that you have to deal with so much variety and like different cases, right? But then, like other than that, are there any other challenges you often face as an IM pharmacist?
Um, Mostly it's just kind of really being up to date with everything, right? So, honestly, what helps with that is social media. Like, I could go on LinkedIn and be like, oh, there's guidelines. I had no idea. And I'll kind of click and read the updates and stuff like that. So, with internal medicine, because there's a lot that we kind of have to cover, and I mean, oncology is a whole different beast, right? Because there's like a million drugs that you kind of got to cover and stuff like that, depending on the different types of cancer. But I would say the challenge is always just trying to be up to date and making sure that we're doing things, that are appropriate according to guidelines. The kind of just so being up to date, word of mouth, like speaking to other kind of IM pharmacists or your other professors that we all kind of are really kind of in communication with each other. And they're like, oh, we do this here differently, or
Mhm.
here we do this, or here this is what we did.
I'm
So
wondering, like, how in depth do you go with the guidelines? Because, see, I don't know, have you looked at guidelines yet, Sia?
For school, no,
Okay,
like or
but yeah,
outside.
guidelines, like, of course, we have some guidelines for our classes. They are very extensive. So it's funny because you have
they
to.
are, but they are expensive, but if you know the background of it, all of it, it's really just kind of adding the
Mhm,
portion on top of it, right? So it's kind of just saying, okay, what's first line? This is what's first line based on this. This is the diagnostic criteria. This is the risk stratification that you kind of got to do. So once you kind of get comfortable, like I know it's a lot to kind of comb through, but once you kind of get used to doing it and you'll do it a lot and you're at ease, it'll come to you like second nature. Be like, okay, this is what I'm looking for. I want to look at the treatment. I want to look at okay, this is what I have to look for. These are the medications that are kind of studied well and approved for these certain indications like that. So it'll come to you.
yeah. Nice. Yeah, because I remember one of my lecturers a few weeks ago, Dr. Wind. I don't know if you know him yet, but he was not complaining, but he was like talking about how like oh, I've been staying up all night because the new sepsis guidelines just dropped like last week, and
They
I was like,
do. And those actually are very long guidelines. Now, I will say, out of all
oh,
the guidelines I read, those are like very, because sepsis is like a lot. It's
mhm.
a lot that you got to kind of consider with sepsis. So, it's definitely a lot to kind of comb through. So, yeah, definitely a lot. I'm still reading through those myself, actually.
I see.
Well, like speaking of challenges, are there any moments where you've ever like been in a disagreement with the other professions at your medical center, like regarding like drugs or treatment, and like how do you handle that?
Absolutely. There's always going to be kind of different perspectives, right? Whenever you think of like how would you take care of the patient. Usually, I like to say I'm like the bad cop sometimes because I'm like, well, I don't know if that's the most appropriate, but and then for me, sometimes it's little just like a teacher moment, right? And being in academia, I kind of have that background to just say, studies have shown this, or there's been many kind of reports and, guidelines recommend this due to that, right? So always kind of leaning back on your evidence to kind of help fortify your recommendation is the best way to go in terms of if there's ever any disagreements and stuff like that. And sometimes it comes to, saying, okay, if this is how you want to proceed, I just wanted to let you know that, that's not the most appropriate recommendation. At least let's just make sure we monitor the patient appropriately to make sure we're watching out for anything that occurs. And that's typically that happens sometimes too. So it's mostly, just using your evidence, and then if they still kind of want to proceed with things, just making sure you kind of find a compromise in the middle.
Mhm. Interesting. Yeah, because it seems like wording is something that's also very important, right? Because one of my electives, I forgot which one, they were talking about how like when you as pharmacists, when we talk to like say doctors, it's important to kind of really watch how how we present stuff and not to kind of make it seem like we're I forgot what the wording what the professor said, but she's like um make it seem like they're the ones making the suggestion, even though you're the one that's actually making the suggestion. So I'm just wondering, is it true that wording really is that important when you have like those disagreements with other
Yeah, I
professions?
would say that. And it's funny because my father always used to tell me it's not what you say, it's how you say it.
Mhm.
So, it's definitely, you don't want to kind of be punitive and argumentative. But you also, at the end of the day, want to also be an advocate for your patient because you are. You are a medication expert, right? And the way that we treat people is with medicine, either non-pharmacological or pharmacological. So you have to kind of make sure that at the end of the day, we are kind of ensuring the patient safety. So if that's compromised, or if you feel as though that can be compromised in any way, it's important to kind of address that. But sometimes there's a lot of gray area when it comes to healthcare. So it's kind of important to kind of just say like, okay, well, if that's what you got to do, at least let's try to monitor. That's what you can do.
Hmm. What would you say is like the most rewarding part of working as an internal medicine pharmacist?
For me, honestly, it's just kind of seeing the patients get better. Really, just kind of seeing the patients get better, and also kind of having those interactions with the healthcare providers and being, like, oh wow, thank you, like I didn't know that, or thank you so much for your help, like I really appreciate it. Like just knowing that I'm helpful in some way. That's all I care for.
All right, so yeah, now we're gonna transition to talking about because like I said, you teach women's health too, and also last month was Women's History
Yeah,
Month.
well, yes, it
Yeah,
was.
so sadly we couldn't get do this episode last month, but we're doing it now, and women's history and women's health is always important, so it's never too late to talk about it. What do you think is like the most like pressing medical issue or the most like pressing issue in today's world pertaining to women's health?
Wow, where do I begin? Definitely, I would honestly just say kind of access to healthcare in general. I do feel like, we do kind of, and I don't want to get political here, but, we do kind of live in current state of things where, there are a small group of people who are not really thinking broadly about the general population of our country when it comes to making sure that women have access to healthcare, and that's not just cisgender women; it's about transgender women as well. Kind of making sure they have gender affirming care, and making sure that at the end of the day, are we want as healthcare professionals want to make sure our patients get better, right? Or make sure our patients are getting the care that they need in order to feel better. And I feel like, and if we are concerned with their safety, that's when we can kind of prohibit people from getting certain medications. But if we're doing it strictly on, someone's morals, which can be subjective from person to person, that kind of can, have an impact on people's access to care, specifically reproductive care, gender affirming care. So those are things that we kind of have to, address. And, there's some headways in that area.
Mm-hmm. What is something the public does not take seriously about women's health?
Um, I don't want to say take seriously, but I do feel like a lot of people, when they say women's health, they kind of just put women's health in a box. But women's health encompasses everyone, if you think about it, right? Because, I mean, everyone has a mother, everyone came from a womb, right? So, you have to kind of understand that, women's health is more than just taking care of a woman. It's actually the entire healthcare scope and this landscape of healthcare. So it's important to kind of think of women's health as it encompasses everyone, not just specifically women. And I mentioned before, it's not just cisgender women, there's also transgender women as well that we don't think about often when we think about women's health.
Yeah, that just reminded me of so for a leap, we had a class on like social determinants of health, and then they presented us like some cases to do, and one of the cases was one where there was a transgender woman trying to get HIV prep, I think, and then it was saying like how do we navigate all these like different factors and kind of give them the best care we can provide while like I said navigating these social determinants of health. And so I was just wondering like because like for us that was just like a case that was just like kind of like a practice case, right? But like in reality, how difficult is it to navigate those social determinants of health, especially for women and like transgender women, and especially like you said, like in today's world some where like some entities aren't kind of um, supporting how to word this.
So I'm grateful that we live in a state that we are kind of understanding of those things and kind of address those disparities. To answer your question in terms of kind of like specifically with PrEP and transgender women, of course, it's kind of looking at okay, what are their other drugs that they're taking, right? Because they're on some sort of gender affirming care, which is in the form of like probably hormonal therapy and things of that sort. So kind of making sure that the medications don't interact with them. The most common ones typically don't. So it's kind of just making sure they have access to it. And, in New Jersey, we do kind of have really good programs to make sure that people who are wanting to get on PrEP have access to it. But, unfortunately, in those states that you mentioned that aren't as supportive and aren't as, understanding of certain things, it is a little bit harder for them to try to get care in those areas. So, it definitely is important as healthcare professionals that we understand that everyone deserves to have access to healthcare, right? It isn't like if you do 5 jumping jacks and you flip around 5 times, you can get, your medication. Like everyone has the right to their medication. That's not fair. So, we have to try to kind of tighten that gap and make sure that everyone has access to healthcare.
Mm-hmm. How would you say, like being so interested in this topic, like how would you say you specifically like advocate for this type of issue to people like that aren't super receptive to women's health and like giving this equality? Like how do you advocate in like academia or at your workplace? Or what are ways to advocate or like tell students to?
Well, this is a perfect kind of channel to do that on, right? Kind of talking about it and having conversations about it is a big thing. And I always like to teach in women's health my students that it's very important to look at the patient as a whole, right? So when we talk about social determinants of health, that can impact how you take care of the patient. if no one has proper access to healthcare because they don't have insurance or they don't have a car, that impacts how you would want to take care of that patient. So kind of looking at the patient as a whole, looking at their circumstances and saying that, the circumstances aren't what caused why they are coming to you, but they definitely can be a hindrance if they're not addressed. That's kind of how I like to kind of look at it. And it's also kind of being, I'm also in NJSHP, the actual, the adult chapter, I like to say, not the student chapter. But so we definitely do work in that area as well, and kind of talking about having CEs about, okay, what can we do as a state, as pharmacists, to make sure that we are addressing some of those things. So there's a lot of headway that we're doing with kind of making sure that pharmacists are able to kind of garnish HIV PrEP in the state of New Jersey, and kind of making sure that in terms of other issues like contraceptives, that pharmacists are able to garnish those as well for patients.
Interesting. A lot of good information, honestly. Um, so kind of not shifting away from women's health, but shifting our focus. So what kind of or what issues do like female pharmacists or female healthcare providers face or compared to like um a male pharmacist or male journalists? Are there more issues they face as female pharmacists or healthcare providers?
That's a good question. Honestly, I feel like, and this is with any, I would say, any kind of women in the field, of course, we live in a patriarchal society, right? So, it kind of takes a little bit more for people to kind of, take you seriously. I mean, in pharmacy specifically, I want to say there's actually more women pharmacists than there are male, if I'm not mistaken, or that tide is kind of changing a little bit. So, I do feel like that also kind of helps a lot in kind of making sure we advocate for certain, issues like women's health. Because we have women that are actually at the forefront of that, right? So, I feel like in any kind of way, it's important to kind of definitely give everybody the respect that they deserve. We all went through the same kind of schooling. We all have the same type of degree. We all have the same type of clinical training and expertise. So you should be held and respected in it.
Right. Yeah. Yeah, definitely um I know it's like one thing I noticed coming to the pharmacy school that there was there was a lot the ratio of female to
Oh,
male was like 75 to 25. And I
yeah.
was like,
It's definitely changing. It's a lot
yeah.
more women, I would
Hmm.
say.
And I was also like very impressed and yeah, it's just nice seeing that
Change.
yeah, seeing that change. Well, look, because compared to other majors like schools,
Yeah.
the ratio
Engineering
is
so bad.
the
My
ratio
my
is quite abysmal.
yeah. My friends will tell me like in engineering, like their recitation classes will be just one girl and like the whole class has got like boys. So
Um,
yeah. But it's like great to see
it's
like
still a
pharmacy.
field that leaves a lot of work with
Yeah.
kind of making sure it's support a lot more people.
Yeah, so yeah, it's nice seeing that pharmacy we're kind of I would say we're like at the forefront of changing things, but we are definitely changing things, and that's nice to
Yeah,
see.
absolutely. Absolutely.
Um,
Okay. Well, it was great to hear all about all this, like about women's health and like educating and then like seeing what you do as a pharmacist. So moving on to a rapid fire question. What's your go-to de-stressor after a long day at the medical center?
I've actually started getting into labor now. Yeah, I'm loving it. I got one as a Christmas gift, and I've been obsessed ever since. I have to get
nice.
another bookshelf because it's all full right now. So it's just like, and they're like addictive. Like I don't know what it is about like building a Lego set, but I'm like upset. So that's kind of what I've been doing.
That's fire. As a professor, what's your biggest pet peeve?
Biggest pet peeve. I wouldn't really necessarily call this a pet peeve, but it's more so like, I definitely want students to kind of, come to me. Like, I mean, I'm not gonna like fight you or something. Like if you have any questions, like I want you to come to me. Like I feel like a lot of people, or I knew I definitely didn't. It was certain professors I did not want to approach, but like I feel like I'm very approachable. Like I'm an approachable guy. Like definitely my goal is to kind of help you through school, right? So if there's anything that you kind of run into, I want you to kind of come to me and say like, hey, like like I have questions about this, like is there something that we could do? Oh, yeah, absolutely. Like, but I want you to kind of take that initiative to kind of come and ask me if there's anything that you need.
Hmm. I feel like that's a lot of professors' pet peeves as we ask this question, but I'll keep that in mind to come up next time. But another one, if you weren't a pharmacist, what career would you do instead?
Oh, wow. Um, I've always been interested in like history and like political science, so I feel like I probably would have been like a political scientist in another
Interesting.
universe.
Another universe. And then I guess one last rapid fire question. What's your favorite type of case, or I guess what's your favorite disease state to kind of treat, if that makes sense? Or what do you think
Oh
is like the
boy.
most fun disease state?
Um, I love heart failure because I feel like heart failure is like it's like putting pieces of a puzzle together, kind of is trying to figure out, which medications work with which patient, and this patient is more bradycardic, so maybe they don't need a beta blocker, or this patient, pees a lot, so maybe they don't need an SGLT2, or they have diabetes when their A1C is like 15, so you definitely don't want to give them an SGLT2 right now. So it's kind of like it differs from patient to patient. So I like heart failure, anything ID related, because I'm really interested in antibiotics and kind of, how this could kind of destroy a pathogen or, kill a pathogen. Like,
If for pharmacy students that are interested in doing internal medicine, what would be some advice that you would give them?
for me, I would say, definitely, like I tell everyone, take every opportunity that you get and put your all into it, especially going through your appies. Appies will be a wonderful opportunity for you to kind of be able to see a lot of different patients, a lot of different patient populations, a lot of different ways that you could kind of go through things. So, definitely take those experiences and, make sure you put your all in it and, just go through it. You'll be okay. You'll come out good and you'll kind of have an idea of what you may want to do and then just go for it. And if you change your mind, you change your mind and you go for what you want to do after that.
Okay. Well, thank you so much for joining us on our podcast. This was a very informational, very just wonderful interview and episode with you. And so thank you so much for taking time out of your busy schedule to chat with us today. And so we hope you enjoyed it as much as we did. Yeah,
I
and then
did. Thank you so much for having me. I really appreciate it.
Yeah, and then to all our listeners, we hope you gained a wonderful insight on what it's like to be in internal medicine. I know today we learned a lot about like the specifics of like PGY1 and like what we could do with that experience and about pharmacotherapy and also diving into like women's health, which was very interesting. And if you have any questions, don't hesitate and please reach out to us.
yeah, if there's anything you want to see on the podcast, let us know. And thank you. We'll see you next time.